Hi, everybody. My name is Mara Yale, and I want to welcome you to this series. We are so happy to be sharing this topic today. I'm going to share my presentation. So today's topic is on the transition from pediatric to adult healthcare. And as with all of our events, we are the Pediatric Stroke Advisory Council, working with clinicians at Mass General and Spalding Rehab Hospital. And today we have a colleague from Boston Children's Hospital. We want to remind you that stroke can happen at any age and may affect your child through their lifespan. And this is an educational webinar, so we're focused on offering information and education, not individualized care. If you can ask questions in a way that's general and not so personal, that is helpful in maintaining your confidentiality. And to highlight where we've been educating on pediatric stroke and brain injury in this format, in person and online for the last 4 years. We started in person. With the pandemic, we've built quite a library of YouTube videos, more than 40 sessions delivered. The highest viewed one has been viewed more than 1,000 times. And the audience is international, and the speakers come from many different institutions. So we invite you to join our mailing list. I'll put these links in the chat. We have a couple more upcoming events for people who are local this spring. So we have a Play to Thrive event, which is for families on the Boston waterfront, doing fun activities like pictured here. And then we have a 5K that's also a fundraiser for our activities to keep them going. The link for the 5K is in that QR code, and I will also put it in the chat. And again, this is through the McCourt Foundation. The 5K is on the Seaport District of the Boston waterfront. And this other link to the right for donating isn't connected to the 5K, but goes through Mass General, and all of it comes to pediatric stroke and brain injury education. And we definitely need your support to keep our series going. So please consider contributing. I'm going to stop my share, and I'm all right. So I'm pleased to introduce Erica Barrett, who's going to talk about her son Ryan's transition to adult healthcare. Thanks, Erica.
Hi, how are you? So my son's name is Ryan. He is 23 years old. We had a normal pregnancy. After he was born, he had stopped breathing. They had to resuscitate him. Briefly, we were told he wasn't going to make it, but he fought through everything, and here he is today. He is nonverbal. He's in a wheelchair. They do say he has some hearing loss. I don't really agree with that, but we talk to him as normal and he understands. So he's completely dependent on us. He uses a Nova Chat to speak, and has no problem getting his point across to me when need be. Ryan attended Beverly School for the Deaf, and when he turned 18, I guess, it's scary. Everything kind of changes. You're worrying about school transferring or going into a program, and then you're also worrying about the healthcare. Ryan had a lot of medical problems around him graduating his program. And it was also the time where doctors were retiring most of his doctors were at Children's, I should say. And it was just comfortable. You go to Children's, it's comfortable. It's your doctors. You get that little extra attention and that little extra hug when you need it. But some of his doctors are retiring, and they weren't finding the answers for Ryan. Ryan, thank God for what Dr. Wishart. That I'm going to say right off the bat. He's the reason Ryan's here still today. He kind of hit like rock bottom over the summer, and through the past year, but he is fighting strong now. I'm here to tell you that changing doctors, changing your healthcare is not a negative thing. I spent way too much time worrying. I wish I used my energy in other places. It's good. Our young adults, they're becoming young adults. They are ready for the next step in the world, just like any other child that we have. The best part of it all was Ryan got a second opinion when I didn't know that he needed it. Things changed for Ryan. I lived the first 21 years of his life one way, and I am now, he's going to be 23. I'm living in a different way. It's a path that I have to fight and go through with him, and he's learning and I'm learning. But the best thing was the transfer of changing from pediatric to adulthood. For sure. It got, like I said, second set of eyes. He is now healthier than he's been in probably 2 years. Everyone was amazing. Everyone is very helpful. You know, you'll get a doctor that you just don't click with, but we had that when they were little, and you just find another doctor. There's somebody out there for everybody. I would say that's the biggest thing. The only thing I will say is a struggle, and that I'm having trouble let going is my pediatrician. For sure, it's someone I can call on the phone and she'll call me back, or there's enough people in the office that know me, like, "Hi, Mrs. Barrett, what do you need? I'll get it done right away." I've been there for 23 years. So I'm still struggling with that one a little bit, but it's my next step. And I know that once everyone's at one hospital, it is definitely easier for all the doctors to be able to work together and see their notes. And so it does make it easier. Don't be scared, do it, and, enjoy them, not wasting your energy on worrying. Because it definitely saved my son. So does anyone have any questions, or?
I think we'll transition to Susan, and then we'll take questions at the end.
Okay.
Thanks, Erica.
Thanks.
Wow, thank you so much. Erica clearly is the expert on a number of things. Let me see if I can share my screen here. I did bring some slides. And thank you all for kind of putting in the chat where you're coming from. And it sounds like people are parents to kids of different ages. You're coming from different places. And we'll try to answer as many questions as we can, including, I like to think about this from everyone's perspective, be a provider, a patient themselves, parents, but thrilled to be invited here to talk about transition from pediatric to adult healthcare, which is essentially all that I talk about for who know me. Again, my name is Susan Shanske. I'm a social worker at Boston Children's Hospital. I'm the director of transitional care support with the Bridges Adult Transition Program, which may sound like a funny name in a pediatric institution, but there are adults for a host of reasons that need to potentially still see some specialists, but mostly our focus is on getting this transition right. And I want to just spend a little bit of time talking about the context of why that's important, and then hopefully bringing some practical tips home for all of you. And then, of course, we'll answer questions we can. Erica's open to it, and I am too. So just to give a frame of reference, when we think of children with special healthcare needs, about 90% of those are growing into adulthood, right? We've done a lot in medicine that's allowed us to have all sorts of special healthcare needs, be it rare conditions to, simple chronic sorts of things that are treated. And so we've got folks living into adulthood, which is, over the decades has been a bit of a change, but fewer than half, and I have the references for you all at the end, but fewer than half really receive sort of robust transition support, by which I mean, this is a little bit more recent study. So the 2016 National Survey of Children's Health. So all sorts of survey questions that randomly come out to maybe some of you on the phone asking about chronic conditions, all sorts of things. When we look at a kind of composite measure of did transition and transfer go well, really only about 17% of youth with special healthcare needs, and even fewer, 14% of those without, are getting kind of robust transition support. I say that not to be negative, to say there's lots of room for improvement, right? In Erica's description of her experience, had we done a little bit more prep, had we reduced a little bit more of that worry, we would have done a little bit better job. So just to give you an idea, some of the outcome measures are healthcare provider, your pediatric provider, Erica said, like the pediatrician, having discussions about eventually you're going to see an internist when you're older, right? Speaking with the patient about that with the family from a, could be a very young age. We'll talk a little bit more about that. Another measure is really around actively working on sort of self-management or gaining skills. So gaining skills here, you see sort of, it's much closer to 78%. We do a little bit better if we think of just this particular measure of transition, that providers do a better job, parents do a better job of sort of let's work on some self-management skills, or even providers, this is a kind of combined question, discussing changes that'll happen with healthcare, right? When you turn 18, you will have to decide whether or not to have the procedure, right? When we talk about sort of decision-making or privacy, some of those changes that happen, that is something that gets covered. Again, a little bit better, but all in, we're not doing a terribly great job at discussing transition. So I think when I'm speaking with patients and parents, I like to say, bring it up with your providers. And definitely I'm telling providers all the time to talk about this early and often. The last measure on there being meeting alone with a young person, right? Giving them some time and space to talk about whatever it might be that's making them worried, but to sort of meet alone so they can talk about private issues. So suffice it to say, there's lots of room for improvement. That's how I like to think about this. See if I can get my slides to work. So, again, for context, patients with chronic disease living longer. Here's an example of cystic fibrosis, where decades ago, we didn't have adults with CF. And now the graphic on the bottom is, there are more patients 18 and up with cystic fibrosis in the United States right now than there are children with CF. So we're talking about people living longer, are sicker as they age. So with some of the chronic conditions, we can see either it's natural progression of the illness. We haven't made it so that everyone lives to 95 with these conditions yet. But also it may be that there are some systems issues. Like it's just a vulnerable time, which I like to call out, not to make people nervous, but because there's a lot of changes going on, which we all know, having gone through adolescence ourselves, that there's lots of changes going on. Erica alluded to, things are different, adult bodies are different, things are happening. So for many, many reasons, it is an important consideration. We've got more adults with chronic conditions that weren't being managed as adults before. And it's, we got to pay special attention to it. Part of the work that I'm very excited, and it's a whole nother hour to talk about, is initiative that I'm doing with Dr. Sarah Spence, who's a pediatric neurologist at Children's. She and I are kind of co-leading this initiative to improve healthcare transition, specifically for people with neurodevelopmental disabilities, which we're defining very broadly as those on the autism spectrum, those with cerebral palsy, any kind of neurological kind of thing going on. We have a collaborative really working to focus on this cohort. And that's because the literature points out, I'll talk a little bit about it, that, this group is slightly more vulnerable. There are fewer providers with expertise in taking care of, let's say, adults with autism. The care coordination services are perhaps not as robust. And there are some challenges that I will point out and highlight, that there's many good things about it, as Erica has so clearly articulated this morning. But just to make sure that we understand that we want to have equitable access for people, all people, and you want age appropriate care. So sometimes when I'm meeting with people at Children's and they really want to stay, we'll say, pediatricians are not as good as internists at sort of screening for adult health issues that are their bread and butter, and they would always ask about it. It's not something that's treated in pediatrics. So, you want people to get the age appropriate care wherever they are up to, and you want it to be developmentally appropriate. Slide is very, very busy. I don't expect everyone to read it, but through this collaborative that's been going on for 5 years at this point, I'd say, we have a very robust group of stakeholders. Some of you may have been in on it, may have heard of it, where we really developed sort of what are the primary drivers where we can make the improvement, really building partnerships, thinking about funding, thinking about how practices are set up, what it's like to be an adult provider who wants to do this well, but doesn't have access to, kind of care coordination support. And suffice it to say, we've spent the past 2 to 3 years with individual teams of pediatric practices and adult practices, working on getting some patients transferred and getting the feedback of what's gone well. So a la Erica's experience of like, okay, now you've transferred over, what can we learn? There's been a lot of that. So I just put it out there. I'm happy to speak more about it. Taken from the Society of Adolescent Medicine, when we talk about transition, we're talking about the purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to adult-oriented healthcare systems. We talked about it. They don't work in the same way. There are pluses and minuses to both, right? But we want people to kind of move. Some folks actually might not move out of a practice if your child is seen and you're seen in a family medicine practice, right? They see people from birth all the way through, but there are changes that happen regardless in the medical care, also in how, again, the transition related issues of decision making and various pieces. So we want to do that and call out. We'll use the word transition. Sometimes, you may come to this talk thinking about transition as specifically about aging out of the school system. People have a lot of kind of definitions. We're talking broadly transition as a process over time. It's not the same as the transfer of care when you might get established with a new healthcare provider. So I just want to call out that transition is, and this may be the social worker in me speaking, it's developmental, it's a process, we're working through it, right? And that could start very, very early. When you're thinking about self-management skills, you teach your 4-year-old to say hello at the doctor. Like you teach them that's a communication skill if they can engage at all, that they can wave, they can point to where their body hurts. So we're going to talk a little bit about some of those particular skills. So this slide describes somewhat the transfer process in an ideal way. My colleague, Dr. Euler, the director of our Bridges program, and his colleague in the CF program as well, really doing sort of an active preparation over time. This is ideal in pediatrics, right? You're speaking to the pediatrician about this a lot. You're thinking about what skills need to be learned still. A therapeutic discharge with conversations between the pediatric provider and the adult provider, and then everyone kind of getting set up well. And it does happen. It doesn't happen unless we're planful and purposeful about it, right? As we said, but it absolutely can happen in this way such that you get folks who sound like Erica does now with the like, wow, this worked out. I can tell you it didn't work out, but this is how it worked. And this is what worked well for me. So just to kind of give an ideal goal there. Just to give a sense of what we're talking about and sort of how long this has been a discussion, right? When I say children are living longer, okay, great. The first consensus, so the American Academy of Pediatrics and internal medicine folks and family medicine folks all together in 2002. So that may feel like a long time ago, and for some it's a lifetime, but really only 20-ish years, right? Where the first consensus statement came out that said, transition is an important topic to be discussed. We need to do well with this. Here's how. They updated that in 2011. Again, still consensus statement about this. And here's the point at which practical tools were sort of put in place. This is where GOT transition was developed. Those may be familiar. If not, I'll give you that link. You'll become familiar. The GOT transition kind of guidelines of here's how to do this. And at that point in time, also, there was sort of a call out to others, other specialties to think about this as well, right? So it's not simply a pediatrics problem in terms of your pediatrician, but also in terms of pediatric specialists, et cetera. The 2018 updated guidance really gave a lot of sort of here's the QI approach. That's where it was, identified that there are some populations that may struggle with this more than others. Those with behavioral health needs or in the foster care system, or those with intellectual and developmental disabilities. So let's pay very careful attention to what's going on and, really adjust as needed if we need to pay more attention to some of the groups. Also gave a lot of very helpful updates on here's what's going well. And so this is something we're talking about more, not just us on this call, even the healthy people goals, right, for the country. The Healthy People 2020 goals included, let's increase the proportion of youth with special healthcare needs that discussed, right, that's one of our outcome measures, that discussed transition with a provider. And Healthy People 2030, looking forward, again, has, outcomes of speaking privately with the provider, transition support, whether or not you have special healthcare needs, which I think is a really important thing that's been pulled out, that basically everybody needs to stay healthy and you're going to have to move from pediatric care to adult care, whatever your level of medical need may be. Just to, sorry, to call out that there are specific, when we're thinking about a pediatric stroke survivorship population, sort of for this group, specialists then did develop, here's what happens in this population, here's what's important to us. So neurology specifically has that, and then develop some practical guidelines from there, which I'll point you in that direction as well. So in that 2018 article, and we'll just put all the barriers right on one slide and then move forward with what we can do next. They really pulled out from sort of the literature, and this resonates with lots of people's experience, my own and yours, I'm sure. On the youth and young adult side of things, and parents, really, there's a lot of fear of a new healthcare system, or just if you're familiar with the place, everything from like, I know where to park and I know who to call, right, is it makes it harder to go to a new place. That's true. Change is hard. But there are some pieces where inadequate planning really showed itself during the pandemic, especially when people abruptly had to potentially transfer care and there was no kind of plan for that. Systems difficulties can include everything from insurance challenges from the patient side of it, to even just, wow, the medical record here doesn't talk to the medical record there, and you don't have what you need to sort of help take care of my kid. There's a lot of systems challenges. From the clinician side, as mentioned, there are some current providers, may not have had as much training on some of the conditions that they're seeing in adults now as is currently happening in medical school. If those, if we weren't seeing it as high in numbers, it wasn't part of the expected practice, and now it is. There are definitely different systems for care coordination and things that are applicable in the pediatric population, or you might have a whole care team and the child life specialist and the social worker and the kind of everyone, and the adult providers don't have access to those things in the same way. So it's just sort of set up differently. Of course, you can figure out who your people are, kind of on the adult side as well. But so those are just some of the barriers that are listed, especially in that particular consensus statement. So getting people, there's lots happening now to address these things, and training on not only transition, but the care of adults with, pediatric onset disorders, all sorts of things that are in the works that I'm very excited about. But these are real barriers. And again, folks who, if your child was born around the time that the consensus statement started, right, if we sort of put it in that frame of reference, then your family is moving through this as we all learned. So that's important. And I'm hopeful that 10 years from now, we'll be doing a better job than 10 years ago. And, each thing, but it is just to kind of put it in perspective a little bit. More perspective. This is all happening in a context. This whole moving from your pediatrician to the new internist is like one little piece of life. You all have lots of things going on in your families. A person is certainly not only a patient, or not even mostly a patient, right? They've got a whole host of other things going on. So just to put that in context, and a few things that come up when people talk about transition. On the left side of my screen here, I have a picture of 2 PDFs. These are available on the social work transition site. They're PDFs with information hopefully helpful to families. What happens when I turn 18 is for our young adults who have to consider, gee, do I still want my mom to call and get information? What, how do I assign a healthcare proxy if I'm not well? Kind of, how does that work? And then what happens when my child turns 18 is a lot more information about guardianship. Guardianship is important, and decision-making in general, right? Because when your child is 17 and 362 days, right, you are making the decisions. The minute they are 18, that day, and it's very clear, when an 18th birthday is, as much as maybe you didn't talk about when we're leaving the pediatrician, or maybe we're not sure when this is happening. We know when the 18th birthday is, and legally, any young person automatically has full responsibility to make all of their decisions. For many patients who can't, and lots of 18-year-olds are not developmentally ready to make a lot of decisions, but for folks who have true intellectual disability, really can't understand their medical needs, name them, advocate for themselves in any way, and full guardianship might be appropriate. In Massachusetts, and I'm not sure who's listening from where, in Massachusetts, the guardianship process is set up to be as limited as possible. So a person should maintain as many rights as they can, and will just support them in the areas where they need help. I will say this is, every state is a little bit different. This is a court process. If someone needs to get guardianship, it is its own whole series of talks. But to think about decision-making, we're here, and supported decision-making is something that is a formal process in many states. Massachusetts is working on that. I'll give some resources at the end, but for all of us to think about who's going to help make decisions. Another hugely important piece of the context, which Erica mentioned, right? School. Like, young people are in school. That's most of their day, right? That's where they are. We're talking about now moving on out of, maybe they had an IEP, maybe they had a 504 plan, depending what it is. Maybe they're moving on to college, they're moving on to work, they're moving into a day program. This whole context also has its own sort of transition plan, and there are resources for that. The Federation for Children with Special Needs has, a tremendous amount of information about that educational transition. Again, its own whole series, which probably we'll talk about. And on the right here, I put our insurance booklet, again, from the Social Work Transition Committee website. Health insurance is another part of the puzzle. So just to say that, right, if a young person's going to stay on their parents' health insurance till age 26, if they'll stay on past as a disabled adult, if they've become eligible for mass health, they weren't, and their secondary insurance. So I'd love to talk about all of these things, but we're going to focus a little bit on sort of the transfer of medical care. And this is part of it, right? The insurance is going to impact that. Thinking about decision making is definitely part of what we need to think about when we're thinking about making medical decisions. So I know that there's rich context for all of you and feelings. This is possibly what happens just when you invite a social worker to give the talk, but I think it's really important to say this. People have feelings about change, about leaving a relationship with a long-standing provider. The feelings that the patient has and that the parent has may not be the same. There's research that shows this. We've certainly talked to young adults who are like, I am done with this patronizing attitude of the pediatrics thing with my parents being on top of me. I need to test this out. I can't wait for the adult provider to ask me what I think. Make great use of my new PCP, but it is challenge for the most part. And I just did a fairly extensive literature search on this and scoping review. For the most part, it talks about the difficulty of leaving long-standing relationships. And I think the way that Erica described it is, it's true. It's change and their new relationships, and that can be challenging. The beauty of it is, that you can build a relationship, and this new adult relationship with a new adult provider is potentially going to be even longer, right? So the time to get connected. I will just, and Erica illustrated this already quite beautifully, but with that, with the NDD initiative that I mentioned, we did, in partnership with the ARC, very informal survey, but sort of asking families about their experience. So this was only 30 respondents telling us, how confident are you that your family member will be able to sort of transition and transfer by age 26, and only 7% of them thought that they could. But it's interesting, sort of the respondents who had older children, for the most part, people were feeling pretty satisfied with the transition process, right? These are their feelings. They felt satisfied, felt like there was a good fit between the new provider and the patient, that needs were taken care of, and that they appreciated the support staff. So this just gets to the idea that, like, you can build the new relationships, and it is hard, but again, I think Erica described this even better. So I'll just let it be with that. I'm going to move into a few resource related things. So you have them, and then hopefully we can discuss more if folks want to. Charting the Life course, you may or may not have heard of, and I'll send you the website. So this is really thinking again about a young person in context, which we all should do, right? And no one's just a patient at a hospital visit. So healthy living being the area in here where they talk about sort of transition of health a little bit more, but charting the life course is one way to sort of proactively plan and think about what do we want for our adults. A transition I mentioned earlier has sort of the timeline of events. Now you'll notice that discussing the transition policy, right? So this would be the part where the healthcare provider says, or you as a parent ask and say, what is your policy? Hey, we're sneaking into adolescence here. We're going to think about in the future moving to an adult provider. Our policy here in our clinic is that patients stay through age 21 or 22, whatever it is that it is, and that we discuss that. And if we're discussing that at ages 12 and 14, it will not be a surprise. I am always, I don't know, challenged with the idea. People are typically not surprised when they graduate from high school, right? They know that's coming. They have mixed feelings about it. They're very excited. They may be terrified. They may be excited about starting college. They may, have vocational goals. The IEP is ending. We know when that is. Part of that is because it's directly laid out in the education legislation that you have to have a discussion and a referral about transition, and that's less so in medicine, right? So we're stealing a little from that model. But God transition is where you'll find here. I'll even more explicitly, the 6 core elements that they define in terms of the guideline and tracking and monitoring. I'll advise you to hang out at that website a little bit if you'd like to think about those. This is perhaps a little bit more so for providers thinking about the 6 core elements and how do I do that? How do I track which of my patients are which ages? How on an individual level am I looking at readiness so I can help this next patient? But I also put a screenshot here of the resources for the youth and family resources. So they have everything from how do you set up a medical ID on your phone? How do you, what is transition all about? Questions to ask and various things. So they absolutely have resources for both providers. And I will say there's a separate set of the 6 core elements for pediatric practices and one for, let's say, family medicine or med peds, where you're staying in the practice, but the way you're being treated perhaps changes. And then one for adult providers, receiving providers. So instead of, a policy about transition, you have a welcome packet. So they've really thought broadly about how this is supposed to go and who's going to be involved. That definitely includes patients and families who help develop all of their tools. So the Child Neurology Foundation, as I mentioned, then specialists often came up with their own. So they took the GOT transition resources and made a transition of care toolkit for patients with neurological issues. Fairly broadly. So that's another great resource. And I think we can share the slides as we will. Folks can look those up as well. The next several slides, in all honesty, I was sitting yesterday in a training my colleagues and I were doing. So the Social Work Transition Committee at Boston Children's has a training, I'm going to say twice a year. We do just a 2-hour webinar for parents and caregivers of those with intellectual disability. That was yesterday's. We talk a little bit about how does the guardianship process work? What do you look for in that? We do one also for chronic conditions. And after a bit of sort of educational slides, which I'll bore you with a little bit, we have a panel to sort of discuss some of the resources available. So I thought these would be helpful to go over, and hopefully they will be to think about from a patient and parent perspective. When we think about transition, we want to be encouraging children to share responsibility for their care and personal management. Now, not every young person can do everything. Most adults can't handle all of the things that they need to, if they had to remember all their pills perfectly and exercise, we probably would all not quite get there. But we understand that scaffolding their learning and sort of building it in as they grow to whatever level they can do it is really important. Coming up with organizational and support strategies, binders, maybe we should update the slide a little bit. I'm not sure that anyone does that. Maybe they put it on their phone. Whatever kind of works that your child's going to remember, this is where I know I can get the information, if they can do it. And if not, that you have it available so that when you are at that new adult practice, it's at your fingertips as well, if you're going to be the guardian, for example. Really involving the child in the decision process as much as possible. That, they're invited to IEP meetings. Some of you may have had that experience. Also participating in medical visits to the extent that they're able. If they can't give a full history, they may be able to, again, as I said, indicate, what symptoms they've been having, something along those lines. And so you want to help the medical team appreciate your child's strengths, them well, their vulnerabilities, and the capacity for skill building, which my colleague who gives this talk tends to like to say, if you do not let them practice, you will not know. kind of what they can do. I shared this once with someone who said to me, I didn't realize, and I saw her maybe a month later, she said, I had not actually ever tried to have my kid fill his own pill bottle, and he absolutely can do it. And now he does. So just, even if they're not managing it all, baby steps for all of us, right? Thinking about talking with others as we're thinking in this transition age, we're not going to know everything for the rest of everyone's future, but thinking about adult life for any child, right? Where might they work? Where might they live? What barriers might this particular child face with their special healthcare needs? So who's going to provide what kind of support? This might be a good place where supported decision-making might be relevant if guardianship's not required. Who can help? Insurance coverage options to guide choices. They're going to come up for you around 18 and 19 with some mass health issues, and age 26 with private insurance, and kind of thinking some of those through. And who's on your team, right? That's back to the charting the life course. Who works with you, who helps you? Well, this is, again, with the child, thinking about the fact that we're going to move. If it's scary for you, it's going to be scary for them. If we're all talking about early, it's great. And being open to those emotions that we said, not to force conversations about it, but being there, being present. It is hard to navigate adolescence and young adulthood the best of times. If you overlay any kind of medical issues where people are very fearful that kind of a wrong move could have some really negative repercussions, then sort of, it's something to be discussed. Another important thing, in working with teens, I definitely have found this. I love to call and make an appointment and speak to my person and figure it out. Where my kid might like to hop on, email their questions to the provider at 11:30 at night and make their appointment without talking to anyone. So there's different ways of navigating that. My child might not have to do it my way, I guess is the way to say it. That next slides, a lot of text, so we won't go through all of them, but to say that, this is work that my colleagues and I have really kind of thought through and through some of that scaffolding. Health self-assessment is one key piece as a first step. Can your child sort of name, I have a shunt? Like if they went to get it, can they name basic things that they know any procedures they might have had or any allergies they might know? They're having symptoms, and sort of you build upon this as much as they can, right? So where ultimately they could show up by themselves potentially and communicate their needs. Communication with medical providers, I feel like is an important one to model constantly. And I think this is true for parents to help patients and definitely for providers, right? You want to be asking the question to the patient or they're not going to answer you. It's much easier to default for any of us if someone's going to kind of try to help us out. So kind of going through the steps of supporting communication with medical providers, up to and including that private visit. Knowing what medication and equipment and when it's going to run out so that we're not, 3 days behind on seizure medications or something along those lines. So this, again, kind of just highlights the tasks. Knowing the names of those things, can remember you need to do them if you're going to kind of do the management yourself, take the medication yourself, do the cathing yourself. Begin helping with instead of just cooperating. Then they're kind of proactively like, hey, letting you know that they're running out of supplies. If they know the name of the pharmacy and can do it themselves, that's even better, right? So access to insurance and medical records. I mean, I think it's reasonable that a patient should know they have a medical record. Many patients we encourage to utilize the portal, which in the adult world is absolutely how everyone communicates. So we might as well teach them that earlier. But it is, extra correct. Talking to insurance companies is sometimes graduate level. Many of you, have advocated with insurance agencies a lot. So that's particularly tricky and not one that gets high scores on our readiness assessments when we're doing them. But the patient knowing that they can access it, that they have insurance, if they can name it, great. If they have their cards, so kind of going through. And last being sort of safety, which we're constantly talking about, general health and wellness all around. Transition age youth are in a time of sort of risk-taking behaviors, and their peers may be, trying things out with substances, there's dating and relationship issues, sort of healthy, body awareness and body safety, kind of depending on how much or how little support they need. So I added those in, again, credit to my social work transition committee colleagues, so that we could just kind of go through some practical tips. But I think, folks have questions, happy to walk through them. I have a whole bunch of references here for some of the things I mentioned. And probably more importantly, some of these websites. The Department of Developmental Services in Massachusetts has like screening recommendations, like, hey, adult providers, you weren't sure what to do with someone with Down syndrome. Here it is, right? So here are the things to think about. Or these are screens that should happen for all adults. So we want to make sure that they're happening, and there may be some special things to consider. I mentioned the Federation for Children with Special Health for Special Needs. In terms of education transition, I think that's a really important resource. They do webinars, of course, as well. Got Transition and the Child Neurology Foundation, both of those having toolkits around transition specific resources. The Life Course Nexus, and again, focusing on healthy living aspect, is probably where my interests lie, but I know that there's lots on that website. Our social work transition committee, I mentioned some of the PDFs. We have some about insurance changes. We have one about the actual transfer of medical care. We have the one about guardianship as well, which is New England specific because it's Boston based. So we do mention states bordering Massachusetts. I did also put actually the probate court site in terms of looking at, the next practical steps for guardianship that might be relevant for some. Supported decision information. This is a national site. Again, Massachusetts is working presently in the legislature. It's being brought forth that supported decision making be a formal process where a person could decide, here are the people I need to help me. With their help, I can make decisions slightly different than guardianship, but just wanted to bring that up as an idea. So I love talking about this and am super excited to talk about transition all day long. I'm going to pause here and sort of, leave my email with people. You're absolutely welcome to email me at any time, but we can hopefully, Mara, if that's okay, I'll stop sharing if people have questions. So happy to do it. And I'm grateful to Erica for sharing so candidly your experiences. And I kind of want to reference them in a number of other places. You brought up a lot of really good points. I appreciate it and helped to frame this really well. So thank you.
Thanks so much, Susan and Erica. I don't see questions yet in the chat, but I want to invite everyone to come on camera so we help foster community here, and just go ahead and raise your hand, either virtual or real hand, if you want to share anything. I see Bonnie, who I know also has a wealth of resources to add to the conversation. Does anyone have any questions?
I guess I can ask this question around, and I think we hinted at it in our previous conversation about this, but the idea of some individuals, and I know we talked about supported decision-making, but the idea of asking for accommodations from a medical provider, as a young person is trying to maybe assimilate all the information that's being given to them in a visit, and if there's a decision that needs to be made. Do you have any recommendations on how families or individuals can kind of go about doing that?
Two things come to mind. One is, like, simultaneously, while I'm thinking about all the education in the provider space, like, I love talking to this group. I love talking to provider groups as well. And I have many colleagues, and there are many options for, books. There's constant education in the medical education space around how do we do this well as physicians, as nurses. So that's constantly happening with trainees. As patients and families, I think we're in a position also to do some of that education and ask for some of those things. Like, I wish I could just say, this is always, there's signage in every room. For heaven's sakes, not even many Boston buildings are handicapped, except like you can't get in with a wheelchair. So like, I am not ignoring those things. I think we'll maybe get there. That's my hope, is that it'll be naturally accommodated, but I think we can help with that. We can ask for things. Hey, this is how I learn best. Would you mind I'm going to write it down. Like learning to advocate for myself as a patient, or a parent helping, a child to learn that throughout the way. I think we'll just have to right now ask for it and build it kind of as we go. But the capacity to ask nicely, like that's a skill to teach children.
I mean, it's encouraging that from the provider perspective that education is ongoing.
Yeah.
There's the power dynamics, that are at play. But of course, being able to identify the need and so that putting it into the provider to know that need exists, and so that even if it can't be accommodated in the moment, that hopefully over time there can be some improvements if that need is identified. So thanks.
I think there are options to put things in the medical record as well that could be flagged. Like if there's something to be noted, like an allergy, we could similarly say needs this communication piece, right? So I think we can utilize the tools that we have, even if not perfect, to kind of make them work for us and figure out how to do it well. But yeah. Thanks for the question, Bonnie.
I think Erica wanted to add something.
Please.
You're still muted.
Sorry. There's just one area that you talked about just briefly, and I did not mention, and actually is a something I work on every day with my son. The transfer from the pediatric world to the adulthood. We're still transferring. We still have like just a few doctors in pediatric. We're almost there. But he feels like children's is what makes him better, because that's where he's been for so many years. He doesn't understand that. Why would we go to a new hospital now? So if I say we're going to the doctors today, oh, we're going to children's. Nope, we're not. And it's repetitive behavior for him. Like, well, I'm not going to get better if I don't go to children's. I think more discussion needs to be spoken to the young adults about why they're transferring. Like I keep repeating to my son, Ryan, that you are now a big boy. You are now older, and this is where you go. This is what we do. It's like you're older now, and then you go to an adult, just be with adults and other ones like your peers. But they feel like they've done something wrong sometimes too. Like I feel Ryan gets really worried and anxious. So it's not only as a parent what I'm dealing with. I had to take a step back and what my son's dealing with, changing doctors. It's nerve-wracking for them, and they get very unsure of who they're trusting. And now they spent so many years trusting one person, and now they have to trust another group of doctors. So just make sure you start communicating way beyond the transfer.
I do. Yes, the one message I tell my colleagues, like, talk about this early. Why are you not talking? It's such a hopeful message. I will give this example that may seem silly, but when you move on, like I'm going back to the school example, you graduate from you're not typically surprised about that. I got to calculus in college and cried every day. I could not go back to my high school calculus teacher, who I love very much, who sat with me at lunch, who was terrific, got me. There's not like that expectation, but you're right, Erica, because we didn't talk about it before, right? Like, no, if that were always on the radar, again, we're getting constantly better at this and we're not there yet, but absolutely. And I think also acknowledging that, not just kind of saying like, I'll move on, right? Because that's also harsh. Of course, who has Ryan known but these people the entire time? He hasn't yet met the wonderful adult people that he's going to be working with. He will. He didn't know the pediatric providers when he got started, but he was too little to know the difference, right? So, but absolutely, I'm all about talking about this a lot and early and often. And I am constantly encouraging colleagues to do the same. And I think we are getting there, but we can't go back in time for the folks who are already 30 and anxious about this, unfortunately. But we're moving forward while we're doing that. But I appreciate the feedback. It's helpful.
I just had a thought about that. If someone has had that much stability, that most of their healthcare has come from one place, to them, doctors are synonymous with that place, right? Like there's no differentiation. So the conversations have to start to be about, well, this is only, some of the doctors, and there's this whole world of healthcare beyond what you've experienced so far. And then I was just struck, yesterday I observed a 9-year-old who, there was a list that the family brought of questions, and the 9-year-old had a question. And there was like a whole negotiation about when this child was going to get to ask that question during the visit. You know, did they need to wait, or could they ask at the beginning, or did they need to wait till someone else's agenda was finished? And I thought that is also sort of a nice way to start to introduce it, that you model that you're going to a visit and you think about your questions ahead of time, and you invite your child to think about their questions as well.
I love to co-create the list of questions on the way to the appointment. Hey, what are our questions? What's the list? You know, but absolutely, like that kind of, it's the simple things, right? It's not like we need to spend 3 hours discussing transition in the visit. I'm being a little, it's how you do it differently, slightly differently, right? Like that, the acknowledgement, like, hey, Ryan, what's bothering you today? What are you excited about? You went to a baseball game. Okay, you're the communicator here. So this is, you know, like just making the eye contact, starting with that. And for developing the list, just each of the things is, I think, really important. I think there's so many little things along the way that we can do to make this just a natural progression.
I wanted to add to that too, as we debrief our visit after, then we're talking about the actions that are on our part or the provider's part, and then even trying to link it a little bit towards, you know, how that affects daily life or planning, like for an example, with working with the physiatrist and, you know, maybe getting Botox injections and, you know, like therapy hard. What are some other alternative ways to really be working the muscles? And, you know, so it just becomes a part of a larger conversation about activities and, you know, exercise and stretching. So I try to also always link what we're talking about in the appointment to what's going on in our life, her life.
And I'm a big fan of homework, Bonnie. Like, okay, great. So we have to make our next appointment. Like, you make the next appointment. When we get up to the front desk, you hand in this, like any little thing that's like
the small steps,
you know, that you have ownership of this. But yeah, I think that that might be even more important than the preparation going to the appointment is the walking out, right?
Sure, we just have a few more minutes. Are there other questions, or Brian, do you want to chime in from the provider perspective?
Yeah, no, the last couple of comments were what kind of stood out to me. I think that difference between the transition versus the transfer, we focus so much on, to some extent, the transfer. Oh, we're going to talk to the next provider. We're going to hand them off. We're going to make sure that maybe we have a joint meeting and then another one. But at the end of the day, that's still a one-off. And that's not the whole process that really needs to take place beforehand. And despite us having all these conversations, and for 10 years, we've been hearing, let's start the talk. Let's start the conversation when they're 12, when they're 13. It is hard, I think, at some level. There's other things, right? You come into the doctor for a reason. So there's other conversations you're having. And kind of figuring out where to focus on that is always a challenge. But I do think it's something that needs to get brought up really early. And Erica, I think the other big part is that I feel like we've had this discussion in two different camps. It's either our type 1 diabetics and they're fully cognitive and they can take over control and we're just getting them ready to do this, or it's our kids that are much more dependent, and how are we getting the right team in place. And we kind of leave out those kids that are fully aware, able to recognize that children's is where we get our care. That's where my doctors are, but maybe not fully aware enough to really comprehend the need and be taking full control over it. And so how do we have that conversation, I think, is a challenging one. But no, this is great. Thank you, Susan.
In recognizing too that there's a delay in development in a lot of different areas. And so that chronologically we're saying, here's the transition age, but the reality is that individual, though, that some stuff is still emerging, but it's later. So it's a challenge for them as well.
a really good point. I mean, I think even in diabetes, the example you give, at this point, I don't think people are feeling like 18-year-olds or all off to war should be drinking, they're adults and they're doing their thing. I mean, I think we've talked about a concept of emerging adulthood, which as I've now heard it described well up into the 30s, like we are not, there's an acknowledgement at Bonnie that everybody has a sort of this new stage of beyond adolescence into emerging adulthood, and that we're all sort of still developing. I feel like the idea that like we would check off all the self-management skills and everyone could do all the things and then they can go to adult care is ridiculous, because as we know, adults don't all do all the things they're supposed to do necessarily. Like it's not about being sort of adherent to a plan. So it's about sort of learning along the way. I think my big thing for providers, Dr. Wishart, and I invite this in all the provider training, there's a nice one coming up in June, I'll send to you, is around like baking it in. Like the discussion has to happen, but if we don't make it such a huge discussion and it's more about just like, hey, what's the homework? How about you do it this time? Like it becomes just a sort of easy for me to say. I realize what's being asked of providers in very short visits, and there's a tremendous amount to cover, but I am always optimistic that can just, it's just a different way of doing it.
Yeah, no, absolutely. And I think the other thing that we've been trying to work on with particularly our stroke clinic is, recognize that there's a team there and it's not all going to happen from one person, right? Your neurologist, your physiatrist isn't going to do everything, but they're going to have, ideally, we're going to have a group, whether there's a social worker involved or, whoever else is there. So great.
I have a very strong bias about the social work part of that, but yes. This has been an absolute joy. I don't know if I'm totally happy to answer questions at some other point as well. And, I can send along the slides to you, Mara, so you have them. I really appreciate this opportunity, everybody.
Thanks so much. And I want to just mention that we focus today on the transition with respect to healthcare, and we recognize that there are other aspects of transitioning to adulthood, and we plan to have at least one session on that in our next season of talks. This is our concluding talk for this season. As I mentioned, we have a couple of in-person events. And I'll be sending a survey about today, and then we'll be doing planning this summer to really map out next year's events. But thanks so much, everybody, and have a great afternoon and weekend.
Great. Thanks, Susan.
Bye.
Thanks, Erica.
Take care.
Thank
Thanks,
you.
Susan.
Thank
Thanks,
you.
Mara.
Thanks, Erica. Bye.